Hi, this is Manos Brilakis from VA North Texas Healthcare System and the University of Texas Southwestern Medical School. This presentation will focus on a case of balloon uncrossable chronic total occlusion, highlighting some techniques and strategies that can be used to approach such lesions. These are my disclosures. And this is the case of a proximal right coronary CTO that reconstitutes distally via collaterals from the left system. This is a fairly long CTO and also has a fair amount of calcification. In a different view, one can see a lot of calcium with the mitral annulus. Again, the PDA is filling by collaterals from the left, and there is a heavily calcified proximal right coronary artery CTO. We attempted to wire the lesion using a fine cross microcatheter and a Pilot 200, and to our surprise, the wire easily crossed into the distal true lumen, as confirmed by the contralateral injection, which is critical before trying to advance equipment over the guidewire. Otherwise, if the guidewire exits the vessel, advancement of balloons or microcatheters can cause a significant perforation. So what do we do for this lesion when the wire went, however the balloons were not able to go through the lesion? The first step is to take a small profile balloon, such as a 1.2 to 1.5 millimeter balloons, and inflate them with a gentle forward pressure into the lesion in an attempt to crack the proximal cap. This was performed in our case, however this was not successful in allowing subsequent advancement of equipment through the lesion. One can either use an over-the-wire balloon or microcatheter, that both have advantages and disadvantages. In general, microcatheters are preferred for supporting CTO crossing because the marker is at the tip, they are more flexible, and they are less prone to kinking. In this particular case, we tried to cross the lesion with several microcatheters. The one that is actually designed for this clinical scenario of balloon uncrossable CTO is the Tornus catheter, which is made with 8 individual wires that are stranded together to form the catheter and is advanced with counterclockwise turning and to be removed with turn clockwise. So there's a clear directionality in using this catheter. No more than 20 turns should be performed in each direction without letting the catheter unwind. Unfortunately, we didn't have a Tornus in our lab during the day, and we tried microcatheter, with the fine cross being the smallest one and the transit being one of the largest profile ones. However, the fine cross was not able to cross the lesion. We then tried the Corsair catheter, which is a catheter designed for the retrograde approach. However, it can be used very successfully for Antegrade crossing as well. The catheter has a tapered, soft polyurethane tip, and then a 20 centimeter screw head structure with a hydrophilic polymer coating, and importantly, unlike Tornus, it can be turned in either clock or counterclockwise direction. We tried the Corsair catheter through the lesion, however the Corsair would not advance through the proximal cap. Another potential technique that requires, however, 2 guide wires is the so-called wire cutting technique, in which 2 wires are advanced through the lesion, then a balloon is inserted and pushed all the way to the proximal cap, and then the second guide wire is withdrawn rapidly, scoring the lesion and potentially allowing advancement of a balloon. After microcatheter failed, then the next step is to try maneuvers that increase the guide catheter support. There are several such maneuvers, both passive and active. For example, in the right coronary artery, clockwise rotation of a GR4 guide will result in deep seating of the guide, or the guide can be changed for a large guide, an 8 French guide, or an 8 French AL1 guide that provides superior passive support. Alternatively, a body wire can be inserted in a side branch, or a guide catheter extension can be used. There are currently 2 guide catheter extensions available for clinical use in the United States. One is the guideliner, the second is the Godzilla. The guideliner comes in 6, 7, and 8 French sizes, whereas there's only a 6 French size for the Godzilla. We did try the guideliner in our case, however, this did not provide enough support to allow advancement of the balloon. And one important thing to remember with any guide catheter extension is that it can cause dissection, so care should be taken before injecting contrast if the guide catheter extension is wedged deeply into the lesion. We then tried with a side branch anchor in which a wire is advanced into an acute marginal branch and a small balloon is inflated. And what this does is it anchors the guide, so when the balloon is advanced through the CTO, the guide provides more support and more force in advancing the balloon forward. However, in spite of our efforts, this maneuver also was not successful in our case. The next step, which are a little more aggressive, we call them second line steps, was to rupture a balloon into the vessel, which is called grenadoplasty. So a small balloon is inserted as deep into the lesion as possible and then ruptured in an attempt to modify the proximal cap. This was not successful in our case, and then we also tried laser, which did not require to change guidewire. In contrast to rotablator, which requires exchange of the guidewire, the laser does not require exchange of the wire. However, once again, laser was not successful in crossing the lesion in our case. And then we came to the last resort techniques, which are subintimal techniques for treating these balloon uncrossable CTOs. This is an example of one such lesion in which the lesion is crossed with a second guide wire in the subintimal space, and then one approach would actually be to re-enter distally and then crush the plaque, which was not successful in our case, as we'll show you in a second. And the second approach is to actually take a balloon and try to crush the plaque, potentially modifying it enough to allow antegrade advancement of a balloon. The last option is what we call the distal subintimal anchor, in which a balloon is advanced over the subintimal guide wire, pinning the first guide wire and allowing balloon crossing over the first guide wire. So this is our case in which we tried to get a second guide wire subintimally. We then tried to re-enter using a Stingray balloon and guide wire. However, re-entry was not successful due to the small size and diffusely diseased nature of the distal vessel. And we then took a second balloon that was inflated distal to the lesion, anchoring the first guide wire, over which we were able to slowly advance the balloon through the proximal cap. The balloon was inflated, and now there is easy to cross the lesion with the same balloon. After stent implantation, a nice final result was achieved. This is a variation of the same technique in which, instead of getting an antegrade subintimal guide wire, the distal anchoring was performed by advancing a balloon through the retrograde route and then anchoring the antegrade guide wire and providing thus support to cross the lesion with the balloon. So to summarize, there are several layers of techniques that can be used to treat balloon uncrossable CTOs. The first one is to advance a small balloon and inflate it at high pressures inside the lesion, trying to modify the proximal cap. If that fails, then we try to advance a microcatheter, usually Tornus, or others such as the Corsair or the Fine Cross, to modify the lesion. If this doesn't work, then we perform maneuvers to increase guide catheter support, such as guide catheter extensions and various anchor balloon techniques. If this doesn't work, and this can be performed in combination, for example, anchor with Tornus or microcatheter in addition with a guide catheter extension. If these techniques do not work, then the next possibility would be to perform grenadoplasty, that is rupturing and balloon into the vessel, perform laser, rotational atherectomy, and if everything else fails, perform a subintimal crossing technique as was performed in our case. This case was actually recently published in the Journal of Invasive Cardiology and is available for anyone to read in more detail about this case. And moreover, we recently published the manual of coronary CTOs that has a full chapter that is dedicated on how to approach the balloon uncrossable lesions. Thank you.